Okay, so just a little FYI, there was a supplemental little 8A lecture. I went ahead and took that off, and I didn't record a video for it. I thought, although it does have valuable information, it didn't really kind of detracted away, I think, from some of the stuff you guys should be focusing on more for exam purposes. So I took that off. And then today will be the last lecture for the biostats section, and then tomorrow we're going to do a nice little group project where essentially we're going to do some article review. So I pulled several articles, and I'm going to kind of just number you guys off, and you guys will get into your groups, and then you'll have an article to review. And I have a paper that'll have some sample questions that I'll have you guys answer. And then I'll give you probably about 20-25 minutes to work on that, and then I will call random groups up to discuss said questions. So that way everyone gets the benefit of discussing the article. And don't worry, it's not going to be punitive. It'll be just an open discussion. We'll talk about different things because, again, you guys have not done this before. It is certainly a skill that you develop over time. So don't worry about it being like me saying, no, that's wrong, you're dumb. That's not going to be like that. Certainly not. It'll be a nice, supportive, good fosterment of education. So anywho, so we'll do that, and then that'll be part of your participation grade, right? So that's like 40% of your grade. So you probably want to be good on that, right? And then at the end of the class, even if your group didn't get called up, you'll still turn in the paper, so that way I can review it and give you guys any pointers that come up. So does that work for you guys?
Yes.
All right, so we'll continue on and do our last section here. I'll try to get through as much as I can. If I can't get to the review, I will do a video and post that online. Okay? The review is going to be pretty representative of a lot of the types of questions you'll see on the exam, so that'll be very useful for you guys. But now we're going to put it all together. We're going to make sure that we can incorporate all these nice ideas that we have and talk about how these apply to the literature. So we're going to talk about appropriate selection of using the right type of statistical test for the type of data you're looking at. We're going to look at various components of medical studies that get published and talk about those. And then we'll look at study design and then some ways that we can help to interpret study findings. So it's kind of, you got all the facts and all the concepts behind you now. Now you can apply it to the actual literature. So yes, you should probably pay attention to this. This is probably the most actionable information you'll get from the class, right? It's how to use this stuff. Okay, so first off, how do you choose the right statistical test? This is a very good question you want to ask yourself whenever you're looking at an article or if you're trying to do your own research. What type of statistical test do I want to run on this data to make sure that it actually is valid and actually tells you something about what you're looking at? So these are some good tables to review for testing purposes. We'll kind of talk about them in bigger detail here. But so say we're looking at continuous data from a Gaussian distribution. Again, Gaussian distribution is also known as normal distribution, right? Not an abnormal distribution, just the normal kinds. And so essentially, the first thing you can do is you can test for Gaussian assumptions, right? Because you want to make sure that the data you're looking at, you want to see whether or not your data actually approximates a normally distributed set of data or a Gaussian distribution. So the way we can do that, one, you can run your normality test, right, to see if the deviations that you're having in your data is enough, far enough away from a Gaussian distribution that it would be statistically significantly different. If not, then you can say, if your p-value is very large, you can reject that null hypothesis and say, yes, this looks like normally distributed data. You can also use outlier tests as well, because remember, what did we say about the means? What are they very sensitive to? Outliers, right? So anytime an outlier is present, you can be affecting your mean. So you want to do outlier tests to make sure everything kind of, is approximating that Gaussian assumption. Now, if you were to describe just one sample, some of the things you can do with that include things like frequency distributions, which is basically just your counting stuff, counting the number of times an event occurs, whatever it happens to be. Keep in mind, you can do sample means with continuous data, but with ordinal or say nominal data, could you do a mean with that? So if I was looking at people's eye colors, can't really get an average eye color, right? Probably be brown or something or gray. But you can't do that really with ordinal or nominal data. You can also look at the median values. You can look at minimums and maximums, look at the range there, the 25th, 75th percentiles. What's another name for those?
Quartiles.
Yeah, the interquartile range, you can look at that. That usually is between 25 and 75%. And then that sample standard deviation, which is basically telling you, what does standard deviation tell you?
How spread out they are on the mean.
Yeah, how spread out the data is, how much variability you have around that mean. Perfect. Okay, so if you were to make so now we're kind of getting into the inferential statistics. So if we're talking about inferences about one population, this is something you could call a one sample t-test, where basically if you were comparing your sample to a larger population, that would be a one sample t-test. We talked much more about, and this is something you'll see much more commonly in the medical literature, but we'll talk about comparing two unmatched groups or unpaired groups. In that case, we'd use an unpaired t-test, right? But then if we were using something like siblings, or we're doing pre-post tests on the same subject, you'd use a paired t-test, right? So it's important to be able to distinguish on a test. If I were to ask you, if I were to give you a sample study in, talking about whether, say siblings were involved in this treatment, you'd be able to figure out whether or not you want to use a paired or an unpaired test, right? Be able to distinguish that. And then when you start to compare multiple groups at the same time, because I could keep running, if say I had 4 different groups and I wanted to keep running sequential t-test on them, what's the inherent problem with that?
Eventually you're going to find something that
so that multiple comparisons issue you run into. So anytime you have multiple groups that are running concurrently, you want to do a test on, you always want to start with your ANOVAs, right? Anyone remember what that means, ANOVA? Analysis of variance. So again, essentially what it's trying to do is to say that yes, there is some difference between these groups. We can't say specifically which one, but we know there's a difference somewhere. And then once you do that ANOVA, that one-way ANOVA for unpaired samples, then you would go ahead and do multiple comparison tests after that. We talked about ways to kind of correct for that. We talked about that Tukey's test. We talked about Bonferroni corrections and things like that. If you were to have paired groups, then at that point you'd want to use a repeated measures ANOVA. Right, so keep in mind which one you're going to use for which type of test or type of sample you're looking at. And then we also talked about ways to explain or predict variables from one another, so you can do things like linear or nonlinear regressions. And then to be able to predict one variable from several others, that's when you start to get into those multiple linear regressions and your multiple nonlinear regressions. Okay? Everyone cool with that so far? Or at least you will be by Friday, hopefully. Okay, so that was probably the longest list, because again, most of the time you're going to be trying to work off the normally distributed data and run tests as appropriate. Now, if you were looking at continuous data from, say, non-Gaussian distributions or non-normally distributed data, this is where you get into what type of test. We said, that your normally distributed data, those are parametric tests. These are going to be what type of test? Non-parametric test, right? So again, because we're not necessarily using the mean anymore, we're going to be using ranking of the values and using the median more so. It becomes much less, kind of sensitive to outliers, so you don't have as much shift in that median just because you have outliers there. So that's why you can use these type of tests. So again, if you were to make inferences about one population, you can use a Wilcoxon's rank sum test. If you were comparing 2 unmatched groups, this would be a Mann-Whitney U test. So again, it's another pretty common one you'll see out there. And then for paired groups, you're going to be using Wilcoxon's matched pairs test. So again, be able to keep in mind kind of what the alternative parametric version is of this, and it will help you remember how you're going to use these tests. So that way you don't get mixed up between a Mann-Whitney U and a Wilcoxon's test, right? And then if you were to look at survival times, this is where we talked about our Kaplan-Meier curves. Those are the nice kind of stepwise curves that are showing you events as they happen. Usually you're looking at death, but you could also look at other things like seizure, contraction of a disease, whatever it happens to be. You can do that. And then you can also do other things. You can make similar comparisons as you would see with some of the other data. These are just some examples that we've kind of touched on previously. Remember we talked about, especially when comparing 2 matched groups, we talk about those proportional hazard regressions, things like that. But just keep in mind that these tests are out here. I'm probably not going to be focusing quite so heavily on these various types of tests here as I am on t-tests and things like that. If you were to have binomial, and when I say binomial, what does that mean?
Yes, no, up, down, 2.
Yes, no, man, woman, and things like that. Republican, Democrat, to be topical. So yes, no type of differences there. So again, usually if you're going to be describing them, you can do one sample test. So again, proportions, you can look at that. And then you can also use things like your chi-square test as well, the chi-square goodness of fit test, and in order to look at differences between expected and actual and expected frequencies. So we can do that with some of this nominal data. And then things like comparing two groups, you can use something like a Fisher's exact test. We didn't talk too much about these, so again, don't get too hung up on these. Those first two slides, I'd probably be spending most of your time doing the studying-wise. Okay, so an article. How is an article structured? What are we trying to get out of an article when we review one? Okay, so why would you read the literature? Like if you think about if you're a working PA, you're out there in the clinical world, give an example when you'd want to actually read the literature.
Best treatment.
Yeah, okay, so what's the best treatment for my patient, right? I have, say, a 64-year-old female with pneumonia. What should I give her? Medical literature can help you answer that, right? What are some other examples? Yep, new drugs come out, new side effects, right? So you can look for new and novel things that are coming out, or look for things that are not common that get reported. So we see a lot of case reports come out of. Right, so there's all kinds of different reasons why you might want to read the literature. A lot of it's going to come back down to how do I treat my patient? What's going to be the best option for them? If my patient has X, Y, and Z risk factors, what are their chances of developing some sort of condition? Things like that can be answered by reading the literature. So these are kind of the structure of an article. This is typically what you will see in the majority of the literature out there. So first off, you're going to have your abstract or your summary. And an abstract is basically just going to be the first thing you read in the article. It's going to be right up at the top. And what does that really tell you? Basically just a summary. It kind of says, like, here's what we looked at, here's who we looked at, and here's what our results ended up being, right? So how much should you take away from the abstract? Should you take away all of your recommendations from the abstract? Right, I'm asking you, so you should probably say no, because that's the incorrect thing to do. Really, the abstract is just to kind of, it's like the trailer, like a movie trailer for an article, and basically trying to hook you in to see whether or not you want to read more, right? It kind of will give you an idea of what the article's about, and whether it might be applicable to your patient or your situation, and then you can start to dig in deeper. You also have an introduction where it kind of goes into some of the background about the disease state or whatever the article's happening to look at, and then some of the most important pieces are going to be coming into this methods section, right? So either materials and methods or patients and methods, however they term it. The methods section is going to be really, really important. We'll dig more into that in a second. And then your results, your discussion, there'll be some key differences between those, and then usually your references and bibliography. So we'll get into more detail on all of these. So again, the summary, the abstract really should just be a concise statement about the goal or hypothesis of the study. And again, it's just really about just getting an idea about what the article is and if you want to read further. You might see in some journals they'll have structured abstracts, so they'll actually have kind of like mini versions of the methods, results, and discussion and all of that. But it really depends on the type of journal you're dealing with. Very frequently, if you ever want to submit an article for publication, they'll really give you very detailed information on how they want everything structured, so you'll know exactly how to write your abstract, how many words it should be, what type of things it should include. You'll then have the introduction. So this is typically going to just be background information on the topic. This is usually good for getting, especially if it's something you're not really well read on, it'll kind of catch you up to where the researchers are and why they wanted to research what they are. It talks about the rationale for the study, and it may talk about other studies that might have looked at the same thing previously and kind of inform what they're doing differently with this particular study. So then again, the methodology is going to be one of your most important sections. This is where you're going to determine whether or not this is going to be applicable to your section, right? So some of the things you're going to be looking at include the patient population studied. So what do you call the set of, it's a hard question to say. So two big things you're going to be looking at include your inclusion criteria, which are, what do you think is inclusion criteria? Yeah, like how does the patient make it into the study, right? Like what defining characteristics do they have to say that, yes, I can include you in the study, right? So whether it be they have hypertension, they are this old, they are this gender, this nationality, whatever it happens to be, you can come into the study, right? And then conversely to that, you have what? Exclusion criteria, right? So this is who you kick out of the study. So you're not cool enough, get out of here. Usually, whatever kind of precipitating or maybe some confounders that they want to get rid of prior to including them into the study. This is how you can kind of weed out some of those people, which is really important because if you're looking at a particular type of patient and they were excluded from your the study you're looking at, how much conclusions can you take from that study at that point?
set of patients?
Probably not a whole lot, right? So it's all this idea about generalizability. How well can you generalize that information from the article to your patient or to your situation? And so if you get very, very strict inclusion-exclusion criteria to where only a very narrow set of patients can actually get in, you're going to make it much less generalizable to your actual, your population you're looking at. So, but again, if you are too broad with that, if you include way too many types of people, what inherent problems can you run into? Yeah, too many variables, a lot of confounders, so it could make it very difficult to actually find statistical significance in whatever it was you're actually looking at in the first place. And more things to control for, more difficult to actually get the stats to really show something. They'll talk about the study design, so we'll go into more detail on the different types of studies that might be done, but this is where they'll say if it's a case control study, if it's a randomized controlled, placebo controlled trial, whatever it happens to be. And they'll also talk about the data collection techniques, which is really important, especially if they're talking about things like, there are multiple reviewers that are looking at charts and trying to take data from that, because everyone looks at a chart a little bit differently. You might get different results. How do they account for that? And they'll talk about the different types of analytical tests or statistical tests they're going to do. So at this point, you can kind of take a lot of information and say whether or not, if their methods are valid, you can say whether or not they're using kind of the right test or not, and that will kind of, you don't have to get to the results to know whether or not you want to throw out the study or not, right? So again, a lot of people will oftentimes skip the method section, but you should always read it to make sure you can generalize that information to your patients. Okay, so then you have the results. So this should just be very, very objective, really just stating exactly what you found with no real color commentary from the researchers. Just to say, this is the drop in blood pressure we had, this is the occurrence of disease state X we had, whatever it happens to be, should be very clear cut with that. You also have your accompanying text, graphs, figures, all that good stuff that will kind of demonstrate all that data. So, and again, this is essential. You should really just be looking at this section in order to determine whether or not the results were statistically significant, whether the data actually works out the way it should. Sometimes they'll report certain values and you do the math yourself and it doesn't add up, right? So there's oftentimes mistakes can be made, or they've looked at a different set of data than what they're actually showing you on the graph, things like that. So always be careful when looking at the results to make sure they actually work out the way they should. And then the discussion or the commentary, this is where the researchers can kind of come in and say, okay, here's what we found, this is what we think it means. A lot of times, it's easy to take their conclusions at face value, but sometimes you need to dig a little bit deeper. Sometimes they might be overplaying the results that they actually found. So sometimes they can go, well, this was statistically different. We know this to be true. This is our results. And they kind of play it up a little bit, even though it may not be clinically significant, right? So make sure, it said, we found a statistically significant difference here. We dropped our blood pressure by 2 millimeters of mercury for this drug that costs 4 times as much. Who cares, right? So again, they'll be able to kind of talk about their results and whether or not you want to lead to more research. Whether or not they had any type of limitations, which are very, very important. They may talk about different confounders they may not have controlled for, different things like that. So they say, here's our results. Should be pretty well tempered and not be too extravagant with some of their findings. And then again, this is going to be the most speculative section, so this is the one you should take with the biggest grain of salt, at least for taking conclusions away from it. And then obviously your references should go at the end. If it's not there, you should probably be pretty suspicious because everyone should be referencing all of their stuff. And this is very good as well. So if you want to go deeper into a topic, so say you found this research article very interesting, but you want to kind of dig a little bit deeper, oftentimes you can start to kind of go down the rabbit hole a little bit and start to find different articles that would talk about this same subject. Okay, so again, when you're approaching an article, essentially, you should be pretty selective in what you're reading because, just the sheer number of articles that come out every month, it's impossible to keep up, right? So for me, like what I'm interested in is going to be tox stuff, right? So I'm really interested in toxicology. So if, a new article comes out about snake bites, I'm already on that listserv, so I already have that come up to me every month. So it tells me these are the interesting, envenomation articles that came out this month, or these are the interesting pediatric toxicology articles that came out. So you can find listservs like that for your particular area of interest if you like. They'll kind of serve that up to you, which is kind of nice. Basically, you start off by reading the abstract, figure out whether you want to actually dig deeper, if you want to read more further into that, and make sure to be careful not to equivocate between different articles. Make sure that you realize that there are significant differences between all articles, and you can't just say, well, this one said this and this one said this, so it must be true. May not be. It could have been looking at different patients, could have been looking at totally different circumstances. Then again, you're going to look over the article for a quick review, look over the graphs and tables, and then kind of get an idea of the article, kind of look at the structure of it and whatnot. And then you can really start to dig in a little bit deeper. Again, look at the method section, focus on the design and the analysis of the studies. Make sure that those are valid with what you are, what you've been learning in this class. And then, as any new information is presented, is only going to be as sound as the study's planning and execution. So if they had really crummy methods, it probably means the data is not going to be super great, and you can't really take a whole lot away from it, right? Because you assume, we talk about peer review all the time of these articles, and you'd assume that every time you submit an article, it gets peer reviewed with a fine-tooth comb, and every single inaccuracy and every typo and everything like that is weeded out of the article. Think that usually happens?
No.
Mistakes get made all the time, right? I've submitted a number of articles where they totally miss major typos, or they miss, some of the stuff didn't actually add up right, so I had to make corrections afterwards. Because the researchers are human, they're going to make errors as well. But just because something is peer reviewed does not necessarily mean it was been vetted by the absolute guru of every subject, right? Sometimes it's just a regular dude that works in the field, may not have be as well read as you might imagine, looking at it and say, okay, it looks pretty good, go ahead and publish. And again, the rigor of the peer review is going to depend on the article or the journal you're dealing with, right? So you can have really big journals like JAMA or Lancet or American, what else am I thinking of? Nature, stuff like that, where it's going to be a very, very in-depth review. It's very, very hard to get published in those because it's such a big article. Really just major groundbreaking work is going in there versus very kind of small rinky-dink kind of operations where you can almost pay to get your stuff published. So just keep in mind that there's a definite range there. Okay, so moving forward, we'll talk about study design. So this is good information to have. So basically when you're looking at studies, you kind of fall into one of two categories. So it can be a descriptive study, or they can be more explanatory. And then as you break down the explanatory studies, this is where we're going to be looking at either experimental or observational studies. So we'll get into more details about each of these as we move forward. So when you're looking at descriptive studies, these are probably the easiest ones to get published. So if you find, say you're out in rotations, you see a really cool case, something that's really unusual you've never seen before, and you want to publish it, that might be a really good route to go. And it's a good way to get a first publication out under your belt. So again, a lot of times these are going to be recording events, observations, or activities. And so these are where a lot of things like case reports are going to be coming from, are these descriptive studies. They don't actually offer any kind of new evidence. But they may be hypothesis generating. You may say, okay, that was kind of cool. Maybe we can look at other patients that are similar to that and maybe get an actual explanatory study developed off of that. But again, you can't take any kind of real cause and effect away from these. They're really just descriptive. So like, okay, cool, that happened. Maybe I'll keep an eye out for that in the future. For the explanatory studies, though, these are going to be more comparisons. This is where we're going to see your more observational studies where you're looking maybe retrospectively, and then also your experimental studies where you're kind of going forward, but you're comparing different groups to one another. And now we can start to take away a little bit more information, maybe some cause and effect away from it, and that might be more actionable kind of information. So when we're doing experimental studies, again, we can talk about things like controlled trials. What does controlled trial mean?
There's a group compared to.
Yeah, there's a comparator group where basically they're your baseline, right? So we talk about placebo controlled, where basically because we know the placebo effect can be very strong. You give one group nothing, basically give them sugar pill, and you give the other one the actual drug, and that way you can have a good baseline comparator, right? That's your control group. Clinical trial is just referring to when you're doing trials in the actual clinical world, actually giving drugs to people or whatever the actual situation happens to be. You'll notice I tend to focus a lot on medication studies, as you might imagine, but just realize that it's one of my biases. So again, you should have some kind of active intervention, and notice where you're beginning at with the study. So when you're doing these experimental studies, you're really starting off at the beginning with the study population and then going forward. So you start with your population, you divvy them out into their groups, whatever happens to be based on your inclusion-exclusion criteria. You can randomize them, and then after that, then you're going to start to measure and classify the results, right? And you're going to do your actual comparisons. So these experimental studies are starting in a start point, and then they go forwards. These are prospective studies. You can then have your observational studies, which these are typically going to be retrospective in a lot of cases. But again, they're going to be comparisons to examine and explain different types of medical mysteries. Does exposure to X, Y, and Z cause this, or is it associated with this? And so you can look at three main types. You're going to see case control, follow-up, and cross-sectional studies, which we'll talk more about. So note here with the case control design, we kind of alluded to these previously, where when I say case control, what does that normally mean? So I have my cases that manifest whatever it is I'm interested in, and then what is interesting about the controls?
Controls also have what it is you're looking at, right?
So not necessarily. So it depends on the study design, but just keep in mind when you're doing case control studies that you typically have multiple numbers of controls for every single case that you have, right? So that's why you get a lot of uneven ends when you're looking at these, because you'll have your cases, maybe say 30 cases of this rare disease popped up, and you have say 150 cases controls that you're going to be comparing them to. What does having that many control patients do for me? It helps me to get rid of a lot of those confounders, because I can control for things like age of the patient or disease states or whatever it happens to be. It allows you to get a better baseline to make sure that you don't have a lot of confounders that are affecting your data, right? So it helps you to actually, when you do see a difference, you can rest assured that there probably actually is a difference there. But again, a lot of those are going to be retrospective. You're starting kind of at the end of the time point and then looking backward. So it's going to be a retrospective case. We're going to look to see, okay, I have my cases, my controls. Let me see what the risk factors were that influence this, right? So maybe it was, I'm looking at people who had cholera and people who didn't have cholera. Let me look back to see which ones were vaccinated, which ones weren't. And I can see what kind of the how effective that vaccination was in that case. So things like that. You can do a follow-up design. So this can be where this is a prospective kind of observational study, where basically you're starting with people who have not yet experienced an outcome that you're interested in, and then this is basically your cohort, and then you follow them until the outcome actually appears. And then after that point, you can kind of look to see what risk factors they had or whatever happens to be that influence them to have that outcome. So that would be a follow-up design study. And then you can have a cross-sectional design. So this one is kind of a mix between the two. Essentially, you're going to start with your population or cohort, and you're just basically going to do this kind of slice in time or a prevalence survey, right? Because we said incidence is the cases of new things occurring as time goes forward. Prevalence is going to be when you take that snapshot, how many of those people have that outcome that you're interested in. So basically, you just take time, whatever it happens to be, take that cross section and look to see, who's had the outcome, who hasn't, what were those risk factors, and how did that influence it. So that would be a cross-sectional design. So questions to consider when you're looking at studies, is the design a descriptive or explanatory effort? Is the author simply detailing an experience with cases? Because again, we talked about case reports. You can also have case series where you're looking at a number of people who had a specific type of condition or whatever happens to be. You're looking at treatments or making comparisons in hopes of establishing etiologies or evaluating intervention. So that's one question you want to ask yourself. If they're just really just detailing what they saw, chances are it's going to be more of just either an observational type study or just kind of describing kind of what happened. If you're actually making comparisons, is the investigator observing the course of events or creating an experiment by assigning subjects to receive a pill, exercise program, or piece of health advice? That's when you're starting to get more the experimental type studies. This is where you're actually making comparisons amongst groups. You're trying to draw some sort of conclusion out of that you can apply to other patients, right? So you're kind of looking more at cause and effect. And if I were to try to take cause and effect from the results of a study, do you think prospective or retrospective data is going to be stronger conclusions I can draw from that? Usually prospective is going to be the stronger ones, right? Because I want to be able to say that, okay, I took these people, control for these different variables, I gave one person one group this drug, I gave these people nothing, and then I saw this change, right? That's going to be much stronger to say, yes, this drug caused that effect, than if you were to do, say, a retrospective type study, right? So you always have a stronger conclusion you can draw from that. Okay, so then we're going to talk about some interpretation of the literature. So we're going to look at sensitivity, specificity, and predictive value. We kind of talked about that previously. We're going to go into more detail on how it can apply to some of these real-life articles. Sorry. So for this one here, when we're interpreting sensitivity, specificity, and predictive value, so there was a study that they did basically where they were looking at children and bacteremia, right? So we're looking for bacterial infections in the blood. And their conclusions, what they came out with is they said that, okay, for children who are age 7 to 12, months old, who have and they end up finding a p-value of less than 0.001, they were more likely to have bacteremia. They also found an association with white blood cell counts greater than 20,000 and a temperature greater than 39.4 degrees centigrade or higher, right? So all of these results were statistically significant. So they said, bacteremia happened most frequently in these kids, and they were statistically significantly different than their comparators. So what does that tell you? What kind of results can you take away from that? Anything at all? So you want to be able to use this information to say, well, if I have a kid who's, in my ER that's coming in 7 to 12 who has fever and a high white count, what's the most likely chance that they have bacteremia, right? You want to be able to take some actionable information away from this to be able to better predict which kids have bacteremia and which ones don't, right? Because that could be potentially deadly, right? Whether or not you want to start antibiotics, whether or not you want to do all these different types of interventions. So again, what can we do with this data once we have it? So again, don't be seduced just because it was statistically significant, right? We're going to look at the clinical relevance of this and look at things like the predictability values and things like that as we move forward. So here's the chart they were referencing, and they're looking at this. Looking at the different data, you can see here, they looked at age, they looked at temperature, and then also the white count. You can see where the statistically significant values are by the arrows that are there, right? So basically they're saying they looked at all these kids and they said these are the ones that were statistically significantly more likely to have bacteremia than their comparators, okay? So when you're looking at sensitivity, specificity, and predictive value, just keep in mind this chart here, because we're going to look at more that are similar to this and how you actually measure that. So again, we're looking at sensitivity, and what is sensitivity? Yeah, so if the chance that if I get a positive result, that the person actually had that result, right? So again, so when you're calculating that, you're looking at people that had the test that was positive, that had the disease state, divided by all of the people that had the disease state, right? So it's giving your sensitivity. So if the test was positive, how many of those patients actually had the disease state? And if you're looking at specificity, what is specificity? So if the test is negative,
how's it true negative?
Yeah, is it really a true negative, right? So how specific is it? So if it's negative, this person really doesn't have that disease state. So when you're doing that calculation, you're looking at people who had a negative test where the disease state was absent, so the true negatives, right? You're going to divide that by B and D, so again, you're going to have your false and true negatives combined there, okay? And then when you're trying to get the predictive value, basically it's going to be looking at all the people who had a positive test, what percentage of those patients actually had the disease state. So that's why it's going to be A over A plus B. So keep these relationships in mind, so when you see these values that are popping up, you can kind of make sense of them when we look forward.
What was the predictive again?
So the predictive value is looking at all the patients who had a positive test, which ones of those actually had the disease state, right? So with sensitivity, you're looking at those that had a positive test. How likely is it they actually did have the disease state, right? So that's why it's going to be over, divided by the combination of people who had it and people who didn't, versus those, when you're looking at predictive value, you're just looking at the positive test results. So if someone had a positive test over people who had disease state and not. So it's just looking at all the positive test results. So when you're looking at this, again, you can see how the numbers are being calculated here. So the first one we're going to look at is going to be the temperature, looking at fever, and to see how predictive it is to say that, yes, this person's likely to have bacteremia, right? Because again, with fever, is that a pretty specific symptom or is it kind of more general? It's pretty general, right? Because you can have fever for lots of different reasons, right? You can be constipated and have a fever. So again, we want to see how predictive is it that if you have a fever, you actually have bacteremia, right? You want an actionable information from this. So in looking at this, you're going to see the blood cultures will be, whether or not they actually had the disease state, right? Because if you culture out bacteria, you said yes, you have bacteremia from the blood cultures. And then you looked at the temperature as your test, right? So you can look to see if they had a fever or not. So you see your positives, your negatives here. You can see how everything was calculated out. So basically, it had a sensitivity of 73%. So of those patients who had bacteremia, 73% of them ended up having a temperature, right? If you're looking at the specificity, it only had about 55% specific, so not super specific there. But then when you actually look at the predictive value, it's only about 7%. So basically what that means is, what is the likelihood that if I have a patient with fever, they're going to have bacteremia? That's really only about 7%. So you think that's pretty good, pretty poor?
Not good.
Not great, right? So not super predictive. And this is why a lot of times you're going to look at things like, if you look at pneumonia severity indexes, things like that, is it just looking at one factor? No, so you're typically looking at a lot of stuff, like looking at age, fever, white count, all kinds of different stuff to get a better predictive model. You can see here that just by using one particular thing like temperature, you may not get the full story. So then looking at the white blood cell count here, you can see as well that just because someone had a high white cell count doesn't necessarily mean that they're going to have bacteremia here. So the sensitivity is pretty poor, and the predictive value may be a little bit better than you see with the temperature. But again, only maybe 12% of your patients with bacteremia are actually going to have a high white count. Okay, because again, that makes biological sense as well, because sometimes patients have low white counts, or they can have white counts that are high for various other reasons. So it could be viral, whatever it happens to be. So again, for the temperature to diagnose bacteremia alone, you see that it will properly identify around 73% of those patients who have a positive culture. It's going to properly identify 55% of patients without the disease, so that's that specificity. And again, only 7% predictive value to say that patients with the fever are going to have bacteremia. And then similarly to the white blood cell count, you can see that as well. Again, just the values are a little different. So again, even though it was statistically significant, you can't take these values just by themselves and apply that to your patient and say, yes, you have bacteremia or not, right? Because again, your gold standard is always going to be that culture in this situation. Okay, so then going in, you can start to look at pre-test and post-test probabilities that can be generated from this. And so this is going back to those Bayesian statistics we were talking about previously. And again, with when doing those, you always need to have information going into the study, right? So you need to know what kind of your prevalence of disease is prior to running any test in this situation. So again, your pre-test or prior probability is that prevalence of the disease or condition in your study population. Right, so this is kind of what you know going into the study itself. And then once you have your new information taken from your sample set, you can apply that back, and now you have post-test or posterior probability, and that's going to be the same as that predictive value that we get there. So again, you can just kind of look at some sample numbers there to kind of show you that predictive value or that post-test probability that says, if your patient has this outcome, this is what it's going to be. This percentage of them are actually going to have the thing you're looking for. So here's an interesting case. I'm not sure what year this was happening, but essentially what they were doing, this is in Maryland. Basically, it must have been probably sometime in the 80s or early 90s, I might imagine. But basically, there are some policies that were being proposed by state legislatures to require mandatory premarital serological testing for HIV. And so when they did that, they kind of prompted the researchers in Boston to try to estimate the benefits of doing the screening program. So you imagine if you were testing every single person getting married in the state of Maryland for HIV, do you think that prevalence would be pretty high or pretty low? Probably pretty low, right? As opposed to if I was looking at, say, IV drug abusers. That would probably be a lot higher, right? So again, knowing the prevalence beforehand going in is going to help us to figure out whether or not this might be something that is truly worthwhile or not. You'll kind of see how these results kind of show up. So just to keep this data in mind when you're looking at it, looking at people who actually had true HIV infection versus no infection, and then whether or not the initial test they did before they got married was run here, you can see that your sensitivity was 98.3%. So pretty sensitive. So if they actually did have the disease, it was pretty likely they were actually going to find it. Specificity was also pretty good, 99.8%. You see here that the prevalence of the actual disease was very, very low. So 0.035% in that case. So very, very low prevalence here. And so when you actually look at the predictive value, it only equaled out to be 14.8%. So is that pretty good? No, right? So again, if you had these people who were just doing random, tests before marriage, they came up positive, it was very unlikely that person actually had the disease state. And so we're going to go into the numbers to find out why that is in just a second.
So is the predicted value like what we're estimating it would be the estimated prevalence? Or?
It's not estimated prevalence. It's just saying that if you have, so if I go with the same kind of population, right, because I'm using sample data and applying it back to the general population, I can say that, if you have a positive test, I think they're using like a enzyme-linked immunoassay or whatever. That 14.8% of those patients are going to have the actual disease.
From testing positive.
Yeah, from testing positive.
What's the prevalence then?
Prevalence is going to be, so if I were to actually have, prevalence again is that snapshot. So I know, so I were to say, whatever percentage of people in this room are male or female, right? That's a prevalence of a particular gender. So that was information you had to have going into the study or going into this new test, right? So people, based on census data or based on, say, health department data, they already know that what the incidence of HIV is on average in that population, right?
So they're not the same units, they're different units then?
Yeah, because the predictive value is really just a percentage, just a probability of someone actually having the disease state if they're positive on a test.
And it's always going to be that if it's positive on a test?
Mm-hmm.
Okay.
Yeah, so again, if you're looking at the incident or the prevalence, it's just saying of the general population, 0.035% of those people will have true HIV. Right? Everyone got that distinction? Okay, so we'll look at this in more detail. Okay, so again, high levels of sensitivity and specificity with a very low prevalence rate. So what that means is when you're looking at the post-test probability, ends up at around 15% or so. Every 1,300 individuals that are correctly identified with HIV, there are going to be over 7,600 false positives, right? So how would you like to be close to getting married and you get back one of these results and you're one of the 7,600? You might be a little upset, right? So, and also you're only picking up maybe 1,300 individuals at the same time. So we'll kind of look at those values and kind of look at the money that goes into that in just a little bit. So again, the authors went ahead and they employed a second stage to the screening and submitted anyone who was positive for the initial step, that enzyme-linked immunoassay. If they were positive, they went ahead and did a confirmatory Western blot. And then what they found what that was is that with the sensitivity of 92%, specificity of 95%, they still ended up having 380 people remain falsely positive. Still not great numbers, right? Probably way too many false positives there. So, if they had a better screen or better to screen the population based on the identified risk factors for a better yield, meaning that if you can identify people based on certain risk factors like IV drug abusers, and where the incidence is higher, your numbers of false positives are going to go way down, right? And we kind of looked at an example of that back in the beginning of the class. So despite this, Illinois went ahead and instituted a screening program. I guess it was done in Illinois, not Maryland. The researchers from Boston. But basically, they did, after 6 months, 8 of 70,000 marriage licenses applicants were seropositive. So that many. And basically, they found that the whole program cost around $2.5 million, or for every positive result they had, cost around $312,000. So is that a good use of government money?
No.
Probably.
Just for testing.
Just for testing, right? Just for testing prior to marriage. So again, you can look at these things that even though you may find a random group of people that might have not been diagnosed otherwise, it could be a very expensive proposition. So again, this is where a lot of kind of the cost benefit analysis will come into play, deciding whether or not it's something that's truly worth it or not. You may catch those few people, but at the cost of what? What else kind of gets short shrift after that?
So are we saying that a low posterior probability means there's going to be just tons of false positives?
It just means that if you have a low post-test probability, or that posterior probability, it just means that if someone has a positive test, what is the likelihood they actually have the disease, right? So again, if I have a low post-test probability of 14%, it means that if I tested all you guys and anyone who was positive, 14% of them would actually have the true disease. So you'd like to be higher, right? Because your test would be more accurate.
Yeah.
Yep.
That predictive value matters who you're testing?
Yeah, exactly. So, because looking at your pretest probabilities, like that in this situation, the pretest probability is knowing that prevalence of the disease state going into it, right? So, using data that we collect from the government or CDC, or whoever happens to be, knowing that prevalence going into the situation, that's your pretest probability, and you use that factoring into what your post-test actually is, right?
You have two. I'm confused by the two middle statements.
I think the actual frequency, if you did the based on what you would guess just based on the prevalence, would end up being like 11 people. So even then, they didn't get as many people as you would have predicted just based on the prevalence.
Okay, so the frequency, the data said that it would be.
They said they had 8 out of the 70,000 that were truly positive that they found. Okay. So we can also use some of this to help with, if you're comparing different variables and how it's going to have an effect on your various post-test probabilities, you can actually end up using these likelihood ratios. And these are useful for comparing different things to say, if you have a positive test for this, how likely are you to have the actual disease state versus, say, a different factor. And this seems somewhat appropriate. We're talking about appendicitis. But here we're going to look at different things like right lower quadrant pain or internal rigidity or migration of the different symptoms someone might have coming up with appendicitis, and then how likely it was that they actually have the true disease state. So in this case, your likelihood ratio that you calculate is going to be your sensitivity divided by 1 minus your specificity. Okay, so you can calculate that out. And so obviously, is a bigger number or a lower number going to be more beneficial here? Probably want a bigger number, right? So again, if this is, say right lower quadrant pain is positive, you're going to be much more likely to say that person has appendicitis than say something like nausea and vomiting, right? So you can notice here that very general kind of symptoms have a lot lower likelihood ratio than something that's very, very specific for appendicitis, like right lower quadrant pain, right? So you want some of the higher likelihood ratios. And again, this is a good way to be able to kind of compare different tests, even though they may have different units or they may have different outcomes. You can kind of compare them all kind of apples to apples in this situation. So there can be some difficulty when you're looking at likelihood ratios. They're not all considered equal. So test discriminatory ability doesn't really tell the whole story when looking at this. So if you went back to that slide on the previous, or went back to the previous graph, you saw that migration of pain and abdominal rigidity both had a likelihood ratio of 3.6. And basically just saying that if someone has that particular symptom or sign, they're 3.6 times more likely to have the true disease state than not, right? So you're really looking at these ratios here to give you an idea of just how likely it is they have it. So both of them are going to have 3.6 times, and so when you look at the individual values here, how they actually calculated those from both specificity and sensitivity, you can see here they're a little bit different. So with the migration, it occurs in 75% of patients, rigidity only in 32%. So you can see here how the sensitivity is going to be much different there. And then as far as the specificity goes, rigidity is going to be pretty high, and the migration is going to be a little bit lower at only around 79%. So essentially, even though both of them are useful for distinguishing appendicitis from non-appendicitis when they're present, so if they're there, that's great. They're not really going to be super useful when they're absent, right? So just because they're missing a sign or symptom, some of them are not going to be super useful to rule out a disease state, right? You may need to do more imaging, you may need to do some other tests in order to find out what they actually have, okay? So just keep that in mind. Here we can look at other likelihood ratios. You can see here things like different condition or different aspects of patients who may have had meningitis. So you're looking at college students. You can look at different things like their whether they're freshmen, undergraduates, postgraduates, whatever it happens to be. You look at these different factors. You can see here they're going to use some of this data in a little bit to kind of describe some of these likelihood ratios. So when looking at this, so if they're reporting sensitivity, specificity, and these predictive values, have they actually calculated them? Does the numbers actually make sense based on what the data is showing you? The authors give evidence that they understand the importance of misclassifying these results, whether these false positives or false negative categories. And then has the predictive value been correctly ascertained with reference to the prevalence of the disease in the population? So they need to look back and see what that pretest probability was and whether or not that actually makes sense. Because if they're using kind of bad data to begin with, that might not be super useful for the actual results that they come up with. And then also look at the spectrum that's been considered as well. So when you're looking at these different predictive models, if you're looking at different things like, say you have to consider the spectrum of disease, whether or not you're finding it, very early on in the disease state or very late. So again, does it help you to have, something that's a very high likelihood ratio if the patient's, so far advanced in the disease state that, you can't really do anything for them in the first place, right? You want to be able to find some of these things earlier than later. And you want to figure out, whether the things that you're testing for, is there something easier, cheaper, it's already out there, and this doesn't really matter. So consider the kind of the practical considerations of this as well. Okay, so again, if they're looking for the actual test, are they using a reasonable gold standard? So again, if they're looking for things like pneumonia, your gold standard is going to be chest X-ray, right? So then you can compare other things to that, right? So consider what your gold standard is going to be, and always keep an idea of things like bias that can be introduced. So if someone has a comparative test that comes back positive, you're more likely to look at your experimental one and be like, okay, that person's positive. Especially if it's something that's more subjective, like reading a radiograph. And then, again, just consider the applicability of the test. Does it actually improve upon the present state of affairs? If not, there's probably not a whole lot of reason to look into it. Okay, I'm going to go ahead and give you guys a 10-minute break now. We'll come back and finish this out and then get to some review. Okay, so I had a good question came up, and I guess, and again, this is my first time doing this class, so I'm always, looking for constructive criticism. If I explain something poorly, let me know so I can try to catch up on that. But basically, they're saying that the description of your descriptive studies and your kind of observational studies sounded pretty similar, right? And so I wanted to give an example of the difference. I'm not trying to toot my own horn; I'm just using my real life example, But toot, no. So basically, so I published a journal article about basically is a case report of a young girl in the PICU who had really bad C. diff colitis, and she actually ended up having, we were treating her with oral vancomycin, and she had systemic absorption of it, right? So it's not something that normally happens. It was kind of a unique case. So we published that article as a case report because, and again, the big thing with those is you can't really draw any conclusions from it. It's really just describing something interesting or novel or something you don't see very often. As opposed to my coral snake research, that is an observational study, but the thing here is that basically we were looking retrospectively, taking all that data that had already been collected, and then starting to compare groups and to make comparisons, and then we're drawing conclusions from that, right? So we're taking information from those comparisons and saying that yes, we should be treating patients with coral snake bites in this manner, right? Obviously, it would be better if I could do a prospective study where I could envenomate people and randomize them to either receive antivenom sooner versus later, but you run into ethical issues with that, apparently. So that's basically the big differences there, in case anyone needs some clarification on that. Does that make sense? Okay. So this is just a slide kind of talking about risk again. We talk about risk very frequently. Talk about relative risk when we're comparing different treatments or different different types of patients. So just realize when we're talking about risk ratios that the larger the ratio that's coming up here, the stronger the association, right? So if I say something like giving you this particular drug will cause anaphylactic reaction versus placebo and has a likely risk ratio of say 2, that basically over the baseline or over your control group, that person has a 2 times likelihood of developing anaphylaxis, right? So just remember when we're talking about relative risk, the bigger the number there, the stronger the association and the more likely it is to occur based on whatever situation you're describing. So when we're looking at those cases of meningococcal disease, notice we are looking at looking at the numerator and the denominator in order to determine what the actual risk is, right? Because you're basically just dividing those who have the outcome over your entire population that you have. So the numerator is going to be all the cases in this situation of meningococcal disease reported by state health departments to the CDC over 1 year. And in this case, the denominator, what do you think the denominator would be? Basically all the patients that would be at risk during that time frame, right? So again, if you were looking at a specific group of people who are, say, going to college or a certain age, how you define that, that's what your denominator is going to be. And so again, that's going to be the risk estimates that are coming, that were collected by the Department of Education. So that's kind of where these numbers are coming from. So essentially, when you are looking at and trying to interpret risk, it's important to look at the likelihood ratios, look at the relative risk to be able to determine kind of what those values are. So on that previous slide, if you had a value that was greater than 1, does that mean you have increased risk of something occurring or decreased risk? Increase, right? So if it was greater than 1, say it was 2, you were 2 times the risk of something occurring, right? Or and essentially, if it was less than 1, it would be decreased risk, right? So maybe something is protective from an outcome occurring. And notice when you're looking at your confidence intervals, your 95% confidence intervals, if it crosses what number, because we're looking at risk ratios, what number does it cross to be not significant? It should be 1, right? Because anytime you're doing proportions, you're doing dividing one thing by another, you're getting proportions. You are looking at 1 to be your level of significance, or if you cross that. Again, if I was just doing a subtraction of one mean from another or something like that, then 0 would be your cutoff point.
How could it ever pass 1 if we're taking who has the condition divided by all the people with the risk factors?
Because if you're looking at different factors to it, so if you're looking at age, if you're looking at people who have, say, like the freshmen were at bigger risk, if you're looking at people who are vaccinated, you can look at different factors and start to make comparisons, right? So you can look at different age groups and compare them to one another to say, these ones had a bigger incidence of meningitis, and their risk ratio was this, right?
Oh, ratio.
Yeah, so you're not taking basically the entire population. You can do subsets and start to do those comparisons to see which ones are more likely to have the disease state. In this situation, you're looking at basically women and how much they are exercising, and then what their risk for having cardiac disease is. And so in this case, you can see the number of women. These different groups, the 1 through 5, are basically the different quintiles. So instead of quartiles, these are just quintiles, so basically 20%, based on how much they reported that they were exercising, based on so many hours per week, right? So people that are the lowest, they're going to be your control group. They're going to kind of be the baseline that is everyone else is compared against, right? So people with a 5 in the 5th quintile, they're going to be the most active, have the most exercise. Okay, and so you can start to look at a lot of different factors, and you can start to control for these different factors in order to make sure you don't have confounders that are skewing your data, right? Because you can just look at the women by themselves and just say, yes. And you can look at the outcomes there, the number of coronary events, basically right here, you can see these number of coronary events that actually occurred. And then you want to look at different risk factors to say, like, okay, well, what effect did exercise have on their risk for coronary disease, right? Because you want to be able to take out things like, did they smoke? Did they, did they have a history of hypertension? You want to be able to control for those different factors to say, what effect did exercise have on this? And so in this situation, when you look down here, you can see they did a couple of different analyses to look at the relative risk. And so again, these are your baseline, this the lowest quintile, these are the least active women. So they did 2 of them here. You notice here they did age adjusted, which is controlling for how old they were. So basically taking age out of the equation. And what do you notice here with the effects of exercise? Does it look to be protective or be harmful?
Protective.
Yeah, it should be a protective, right? Because the number's less than 1, right? So the risk of having a cardiac event for people who are in the highest quintile, the most active women, you notice here there was around a 54% reduction in risk compared to people who had very little activity. Okay, so that's kind of what we're saying with the risk ratios. Is how you can interpret that. And then also we did this multivariate analysis. And what do we mean when we say multivariate or multivariable?
Taking out lots of things. It would be like smoking and hypertension and diabetes.
Exactly. So if you read that really tiny print down there, you would see what all the different things that they adjusted for, basically. And so that's important that they are explicit about that, so you know what they're controlling for, you know what confounders are taken out of the equation. And so when they did the multivariate analysis, notice here that your values have changed a little bit. And so why do you think the risk has gone up in those numbers? Because obviously, if you look at between just the age adjusted and then the multivariate, it looks like the risk has gone up for the more active women, right? The number's larger. It's closer to 1. Correct? Well, if you think about it, if you think about the different things you're controlling for in the group that are just age adjusted, there's lots of other confounders that could be going into play here. So someone who's more active, do you think they're more or less likely to smoke? Less likely. Do you think they're more or less likely to have hypertension? Less likely, right? So there's lots of things that would be skewing the numbers lower that if you don't control for them. Besides just age. So when you do the multivariate, you get a better idea of what the actual true effect of exercise has on the risk of cardiac events. Does that make sense? Okay. And just know that if it were to cross 1, the 95% confidence interval would be non-significant. We're just going to take them at their face value that these were all significant. Okay. So here, this would be another one where they're actually looking at the risk of a couple of different things like coronary heart disease and also pulmonary embolism, breast cancer, in women who were taking estrogen and progesterone containing products, so things like birth control, versus just placebo. And so this is part of the Women's Health Initiative. That was one of the big kind of landmark studies that kind of showed this correlation between things like cardiovascular death and estrogen use, right? So this is where you get a lot of those risks for things like pulmonary embolism and stroke and things like that with those use of those products. So anyway, so what we're looking at here is basically you have your number, you have your subjects. The E and P is going to be for estrogen and progestin, and then you have your placebo group. So just based off of that, what type of study do you think this was?
Controlled.
Yeah, so it's a controlled trial, right? Anything else you can take from it?
Clinical, because you're doing something.
Yeah, so it's a clinical trial for sure.
Unpaired?
Huh?
Unpaired?
Yes, this would absolutely be unpaired, right?
Double-blind experiment.
How do you know it's a double blind? Like to think, right? Because then your strength, your confidence in the results are going to be better if it was double blind, because then you remove the risk for bias, or for if people know they're not taking true drug, that might kind of skew their results, or might skew the way they're thinking about things.
How is this ethical?
Because at the time we didn't know. We didn't really know what the true impact of taking estrogens and progesterone was on these risks.
So these people aren't trying to get pregnant, or
No, so if you go back to the actual study, they would exclude pregnant women or people trying to get pregnant, whatever happens to be, and they were probably explicit in what kind of age women they were looking at, things like that. Again, I don't have the full details on the study, but you could go back and read it if you like.
placebo birth control just seems like a
Well, I don't know if it was. These might have been in postmenopausal women. I'm actually not sure what type of women these were. These could have been like postmenopausal women they were looking at. Like you have to go back to look at
We
it.
think of the hip fracture, colorectal cancer, breast cancer, all these things.
There you
Those
go.
would probably be
Yeah, exactly. So let's go with that. So we're looking at postmenopausal women. Let's say that. But anyway, the point that I want to illustrate here. So you're comparing people who got the drug versus the placebo. So we can kind of guess what kind of study this was, and then you're looking at your risk for the different events occurring, right? So we see that for coronary heart disease, that risk ratio is going to be 1.29. So what does that mean to you?
It's high.
Higher.
higher than
So it would appear that there's an association between taking estrogen-containing products and having increased risk of coronary heart disease, right? That's kind of the result that you would take away from that, assuming that it was statistically significant. But notice how you can have these different kind of outcomes. So you can compare all of those, and then they have this idea of a global index. And basically that's going to be looking at all of those different conditions kind of combined into one to see what is your risk compared to taking placebo for any of these events occurring. And you see there it was still 1.15, so it was still increased in that situation. Do you notice anything that's gone down?
colorectal cancer.
And also,
Hip fracture.
yeah, so in those cases, estrogen-containing products would actually be protective for those. Okay, so again, it wouldn't. In a lot of cases, you may have to consider, kind of pros versus cons. You may not want to give these to a patient who already has a history of coronary heart disease because they may be more likely. So again, you can kind of take this information, generalize it out to your patients based on who the type of patient you're dealing with is. Here is a case where you're looking back at the meningitis patients, and again, you can look at the odds ratios. Very frequently, when you're doing case control studies, we mentioned the odds ratios are the best way to look at that information because it's retrospective. You're doing kind of looking at the prevalence of disease versus doing incidence, which you would see if you were looking at it in a prospective manner. So here they're doing odds ratios. You can see the different factors and how they're going to influence their risk or their odds for developing meningitis. So you can notice some things here. Notice anything that's protective?
Employed during school.
Employed during school. Okay, so that appears. It looks like their odds were half as likely to have meningitis as those that did not work.
And those that went to a movie.
And okay, so that's interesting. So again, just because we find statistical significance, does that mean anything?
Yeah.
Possibly not. You need to have some kind of correlation. So again, does seeing a movie necessarily influence your ability or your odds to getting meningitis? I guess it depends on the type of movies you're going to. I don't really know. I honestly don't know. But notice here that some of these will be actually, yeah, so you notice things like active smoking, even though that it appeared to have an increased odds, notice that it's non-significant because what does it cross? Crosses 1, right? You don't even have to look at your p-values in this situation because they put the 95% confidence intervals right there for you. So again, if it doesn't cross 1, then you can consider it to be significant at that point. So again, retrospectively, you're looking at the prevalence of disease in those patients, so you can look at the odds ratios versus when you're going forward and looking at incidence, you can look at relative risk. It's kind of the rule of thumb for that. Okay. You can also look at a term called attributable risk. This is basically going to be also known as the absolute risk reduction or absolute change in risk. So you can see that frequently being talked about. In this case, they're looking at the incidence of lung cancer and also death from coronary heart disease in heavy smokers and versus non-smokers. So you can see here that just by dividing your risk for the event happening divided by your total patient population, you can end up getting the relative risk. or you get the risk of the event occurring in that group, and then you can divide that out to get your relative risk. So as you might imagine, smoking has a bigger effect on causing or being associated with a higher risk for lung cancer or coronary heart disease. Lung cancer, right? And that makes physiologic sense, right? You assume that you're going to have a higher risk for lung cancer from smoking. And then if you were just to subtract those risks from one another, the actual baseline risk value, you end up getting the attributable risk, right? So very frequently this is going to be reported as a percentage as well. We can see, a absolute risk reduction of say 3% or whatever it happens to be. So just a couple of different ways to kind of look at that information. Okay, so here's another thing where we can look at number needed to treat. You guys remember what that is? What is number needed to treat?
How many people you need to treat to get one person to have an effect?
Yeah, to have whatever outcome I want it to be, whether it be prevention of an outcome or to cause an outcome to occur, whatever it happens to be. Does anyone remember how you calculate number needed to treat? Very close. So it's the reciprocal of your absolute attributable risk, or your risk reduction. So in this case, when they were looking at postmenopausal women, so I'm glad they put that in the title there. So they're looking at raloxifene, which is a drug we'll talk about in Pharm 2, versus placebo. They use a couple different doses there. So for one, if I were to do, if I wanted to see if there's any difference in the means between these three groups, what kind of test would I want to do? So I got more than two groups. I want to detect for a difference. ANOVA, absolutely, because that'll tell me whether or not there's any differences between the groups. It doesn't say where the difference is, but it would tell me that, right? So you could do that initially and then start to do your multiple comparisons test. So we'll assume they did that here. But again, the article should tell you in more detail, and specifically in the methods and materials section, they should tell you that. So anyway, so we're looking at placebo versus two different doses of raloxifene on these women. So we're going to be looking at either in those with low bone density, that's how they kind of divvied up the patients, either low bone density or low bone density plus a prevalent vertebral fracture, meaning they've already had a vertebral fracture at some point in their life, and then starting to look at some of these different risks. So here you can see the risk for developing a vertebral fracture between the placebo and then your two different raloxifene doses for this first group here. And you can notice that look at the relative risk, how it's calculated out, and you can do the numbers, and basically comes out to be, I guess, what can you take away from that relative risk?
It's not that risky.
It's not that risky. What is your risk for developing a vertebral fracture while taking raloxifene?
It's less than 1.
It's less than 1.
So it's better than if you weren't on the left.
Yeah, so your risk for developing a vertebral fracture for these postmenopausal women taking raloxifene was about half of those that had placebo, right? So it shows that yes, there's a protective effect here. And then when you actually take the risk, the change in risk, and get the reciprocal of that, you get the number needed to treat. So then you get 46 and 59. What do those numbers really mean? It means that I would need to treat 46 women with 60 milligrams a day of raloxifene, these postmenopausal women, in order to prevent one vertebral fracture. Okay?
And is that NNT?
That's the number needed to treat.
Okay.
Yep. And then on the flip side, with raloxifene 120 milligrams a day, I would end up having to treat 59 patients a day, in order to prevent one vertebral fracture.
So a higher dose is not beneficial.
Right, so at that point, you're looking at the doses, you're saying, well, there's not a whole hill of beans of difference here. In fact, just with this data alone, it looks like maybe there might be some benefit to just using 60 milligrams of raloxifene. There could be other factors as well, looking at things like cost, looking at adverse effects, things like that may influence you to do one versus the other, right? But yeah, so it would appear that either one can help to prevent vertebral fractures from occurring. Notice here that you already had a previous vertebral fracture, so now you're down here in this group. What do you notice about the number needed to treat? How's that changed?
Much lower.
Why do you think that's lower?
Because it's having a bigger impact because the women are already at risk, so they're benefiting more from the drug.
Right, so they've already showed you, they've already had a fracture before, so they've already kind of shown you, they're a little bit sicker, right? They're kind of farther along the disease spectrum, so this would have a greater effect. So I'd have to treat a fewer number of patients in order to prevent a further fracture for these women, right? So that's probably, I get more bang for my buck out of that group than I would from just the people with low bone density, okay? This is some of the interpretations you can take from these type of studies. Okay, so we'll talk about some of the causes. So again, confounding is a very real thing you want to always make sure the researchers are considering when they give out the results. So again, looking at this example here, if you were to compare a random sample that they pulled here for baldness and looking at cigar smoking, what do you think? What do you think about those odds? What does that mean? So the number is greater than 1, right? That's 6.2. So what does that mean?
If you smoke cigars, you'll go bald.
Yep. So it basically means you have 6 times the odds of going bald if you smoke. Does that make sense? Right. So perhaps there are some confounders, some other effects that are going on that may be skewing the data somewhat.
Yeah, I smoked a cigar once.
Maybe correlation maybe does mean causation. I don't know. Anywho, but if we were to actually look at who made up the control group, say people in the control group, their average age was 24, whereas the average age of the cases was 52. Now all of a sudden, does that really make any sense? No, because you're looking at older patients versus younger patients. Of course, they're going to have, age is probably going to have a gretter effect on their balding status than their smoking habits, right? Probably. So if you were actually to look at actually controlling for age, and in this case they just took patients who were 40 to 45 years of age and compared cigar smoking to baldness, what did they find?
Pretty even.
Yeah, so the odds are lower though, so maybe cigars are protective for preventing balding. Right. So basically, there probably isn't really a good correlation there. There's probably not a good good association. If you did the confidence interval, it probably crossed 1 at some point. So it probably can't take a whole lot from that information. So just keep on confounders can introduce skew into the data to make it show something that's not really there, or perhaps maybe obscure something that really is there. So again, risk for errors that can come in your results. This is a good picture to kind of show you that you're looking at your characteristic factor and you're trying to see the disease or outcome, the effect. You think there's an apparent relationship, but really there's not. There's actually something else that's confounding for that. So that's where you see a lot of researchers will want to control for this by doing things like multivariable regressions, right, to make sure we're controlling for things like age and other risk factors. So again, here's another example where they were looking at heart disease and patients basically looking at the control subjects who had no heart disease and then looking at their sugar consumption. And just based on that, you might assume that, okay, well, people who had heart disease were consuming more sugar, right? What are some other things that could affect heart disease rates? Diabetes, family history, smoking could be another one. So that was one of the other things they wanted to look at. Say, well, maybe smoking is having an effect on who's falling into this heart disease category. So then here they can they were able to kind of peel it out and say, okay, well, now here's the smokers compared to non-smokers who have heart disease, and then in the control group here are the smokers versus non-smokers. So this helps to kind of rule out some of the confounding when you're able to kind of look at these individuals' characteristics. So when they actually were doing it and they evened out for the effects there, they found that essentially there's a relationship between sugar consumption and heart disease. They still found that it was statistically significant, but they also found that smoking had an effect as well. So even though smoking might have been a confounder, the sugar still has an effect as well. So again, you really just need to take into account those factors, control for them in order to show significance there to really come away with a conclusion. That makes sense? So even though you're controlling for a confounder, the thing you're looking at can still be having an effect here. Okay, here's another case we're looking at. So this is going to be looking at cases of invasive cervical cancer and looking at patients who had pap smears or not. So in this case, this would be a case control study that are looking retrospectively. This is actually, I calculated it out. These are actually odds ratios, not relative risk, so don't get confused on that. But again, looking at cases of cervical cancer versus the controls who had no cervical cancer, and then looking at the incident, or looking at those that had pap smears done. And so what do you notice with these results if you're looking at all subjects? What would you take away from that? So essentially, those patients who did not get a pap smear were 2.7 times more likely, or had 2.7 times odds of developing cervical cancer, right? So this should be showing a protective effect for getting a pap smear, right? Which we know to be true. This is probably a study done back like in the 70s, I think. And so again, what you can also do is look at in each of the individual risk factors to see like, well, maybe age has an effect here. And what do you notice with these? Right. But they're all pretty consistent, right? They're all going to be consistently showing that those that did not get a pap smear were more likely to develop cervical cancer, right? So this is just really showing that even if you start to look at things like income, which could be affecting access to healthcare, things like that, looking at education, which can do the same thing, that really all the effects are still consistent. So even though these effects may be confounding the data, they all basically show that, you know, not getting a pap smear can increase your risk for cervical cancer, or at least not detecting it, right? So just ways to control for that data to show that you can still find these results or probably still make sense. They're still consistent. Okay. Again, they're all the same magnitude, still the same direction. So we can take conclusions away from this. That yes, we think that not getting a pap smear probably increases your risk for getting cervical cancer, or at least not detecting it. Okay. Again, so when we're doing these multivariate analyses, it's just a good way, as we mentioned, to control for a lot of these things. So again, when we're looking at those women and looking at the different exercise, or how much exercise they had based on the quintiles there, you can see where we were controlling for a lot of those factors like smoking, multivitamin use, ethanol use, all those things, to make sure that the thing we're looking at, the exercise, what effect that truly had on our outcome. You can also do things to make sure, look at different dose responses to see how significance can change over a scale. So in this case, when we're looking at endometrial, incidence of endometrial cancer, and then looking at the dose of estrogens used per day, you can see how the relative risk will kind of change there. Notice how as the dose goes up, what happens to your relative risk? Yeah, it's kind of going up as well, right? So there could be a dose response here that you're starting to notice where the relative risk increases as you increase your dose, meaning there is a dose response there, right? So this could be some things you can see in some of the data that shows you how the magnitude of that risk is consistent with the dose that you're giving there. It's not just that you're receiving estrogens, but it could be the dose of estrogens that you're receiving. Here's another one where they were looking at cell phone use and incidence of brain cancer. You probably know that not to be true. But again, we were even looking at things like how long someone's been exposed to something. That could be considered a type of dose. Looking at how often they're using something, for how long they're using it, against all kinds of types of dose. In this case, they end up finding no significance there. Those p-values you notice are all greater than 0.05. And then they also have to consider, biological plausibility for some of this stuff. This is a case where they're looking at estrogen use and endometrial cancer, but they're looking at the time since first use. And you can notice here that, obviously they've never used it. That's your baseline, that's your control. So they have a relative risk of 1. But notice how it starts to kind of go up. So the longer they've been using it, your risk goes up. But then all of a sudden it starts to kind of trail back down. And so sometimes the biological plausibility doesn't really make sense with that. So you have to kind of take it with a grain of salt to realize that, maybe the results aren't necessarily representative of what the true case is. You may need kind of reproductive studies to really show, or studies that reproduce this effect to really kind of delineate what's actually happening. Okay, so some questions to consider for this. So have the authors addressed the possibility that chance, bias, or confounding factors have been responsible? Very frequently, they'll either control for that in their methods and materials, or they will talk about it in their conclusions, saying that, hey, we may not have had enough patients that had this particular condition to really make the data really robust. It should be explicit when talking about that kind of thing. If they've listed the confounders, are they reasonable? Are they leaving off really kind of obvious things like smoking, or are they including way too many granular things? Any known risks that are not included, and could the unmeasured confounders be playing a role? And hopefully they've kind of done their best to control for a lot of those different things. Very frequently, you'll see when they're looking at patient populations and studies or looking at the samples, they will do t-tests to compare, say, average amount of smoking per day or something, to make sure that there's no difference between the groups. And so that's a way they kind of frequently try to show you that, yes, their groups are very similar to one another, and that these factors should not be confounding, right? So you'll see that very frequently in the literature. So again, have the steps been taken to control confounding? Was matching employed when the study design was created? So make sure you're matching patients that are similar to one another as you do the randomization. That can be useful. Or if they use some kind of multivariable techniques to help control for that. And then if the authors have supplied evidence that potential causal factors are not confounded, what additional evidence is there to suggest causalities? And what can you really take from that once they've kind of taken into account all their confounders? So, That's it for the last section. So this will end all the test material for Friday. Do you guys have any questions? I assume this is how you guys feel right now.
Good assumption.
Any questions at all? Okay, do you guys want me to start doing the review? Maybe. I'll start now, and then I can post the rest as a video. Would that work for you guys? Yes.